and welcome to the final CAP media briefing for 2021, which is live streaming on YouTube. Thank you for joining us today. My name is Dr. Emily Volk. I am the president of the College of American Pathologists and chief medical officer at Baptist Health Floyd in New Albany, Indiana. I am also an associate professor of pathology at the University of Louisville School of Medicine. In addition to discussing updates on COVID-19 testing, there are some other pathology-related topics we feel are important to share with you. A recent change in the way pathologists test for kidney disease and how that will help change racial inequity in healthcare. A shortage of forensic pathologists in the United States and the problems that creates. And the dramatic rise pathologists are seeing in cancer diagnoses and the severity of these cancers during the pandemic. I would like to welcome 3 CAP members into today's discussion. Dr. Sue Chang, Amy Carger, and James Gill. Would you all please introduce yourselves, starting with Dr. Chang. Dr. Chang?
Hello, my name is Dr. Sue Chang. I am an assistant clinical professor and interim chief of anatomic pathology at City of Hope, which is a cancer treatment center and research facility in beautiful Southern California. I'm also the incoming chair of the CAP's Professional and Community Engagement Committee.
Thank you. Dr. Carger.
Yes, hi. My name is Dr. Amy Carger, and I'm an associate professor at the University of Minnesota, where I direct clinical lab testing at the University of Minnesota Masonic Children's Hospital. And I'm also system director of point-of-care testing at the mHealth Fairview system. Lastly, I'm the current chair of the CAP point-of-care testing committee.
And thank you. Dr. Gill.
Hi, I'm James Gill. I'm a forensic pathologist, and I'm the chief medical examiner for the state of Connecticut. I have academic appointments at Yale and the University of Connecticut, and I'm the chair of the CAP Forensic Pathology Committee.
Well, thank you all for being here. Just yesterday, a new COVID antiviral pill in development by a leading drug manufacturer suggests this drug retains its effectiveness against the fast-spreading Omicron variant, as well as being effective with the other variants and keeping patients out of the hospital. The company has requested an emergency use authorization from the Federal Drug Administration, and we may be seeing this pill available in the next couple of months. In the meantime, Omicron continues spreading across the U.S. and the world. We do know that Delta variant continues fueling a surge in the U.S., and it is driving U.S. hospitalizations, and that means testing will continue at a steady pace. More than 100,000 COVID-19 cases are being diagnosed daily, and the U.S. is experiencing 1,100 deaths every day. Reports on the Omicron variant are constantly changing, and whatever variant comes after that, and we know they will come, the bottom line is trusting the science, vaccines, and boosters, dispelling medical misinformation, and being transparent. So let's talk about that. What effect is the lack of trust in science having on all of us, physicians as well as the public? I can tell you, for me, it's exhausting. But I just don't feel like we can give up trying to get more people vaccinated, even though those who have indicated they aren't interested or are afraid. When I've talked with hospital staffs and patients about getting vaccinated, I work very hard to meet folks where they are so I can truly hear their concerns. Pathologists are critical partners in therapy development and decision-making. During COVID-19, we have been essential in evaluating responses to several potential therapies. This includes plasma therapy and monoclonal antibody therapy, as well as vaccines. In the midst of the most stressful long-term crisis many of us will ever experience, it absolutely can be difficult to think about our broader responsibility to fight misinformation and to engender trust in science. Our duty as physicians is to prevent harm and to inform the public about what's true in science and medicine. We must speak up when we see misinformation. I'd like to ask all of you to weigh in on this. First, Dr. Karger.
Yeah, so I totally agree with you that it's very important to fight misinformation. And I think I'm like you, I'm also exhausted and frankly demoralized by what I see out there and all the incorrect things I see. But I do find hope in some of the personal interactions I've had. In fact, a couple of months ago, I did decide to put a post on social media just dispelling a lot of the myths surrounding vaccination for my friends and family to read, because I do have several who are vaccine hesitant or not vaccinated. And at the end of that post, I said that people could contact me directly to have that personal conversation. And I was pleasantly surprised that a lot of people reached out to me. A lot of people who had questions or concerns or fears about the vaccines reached out to me to have that dialogue. And I was able to have good conversations and try to extend sympathy and understanding for where they were coming from, but also try to provide truth and scientific basis for what I was telling them.
Thank you for that, and thank you for being a beacon of truth during all of this. Dr. Chang, can you share your experience?
Sure. I have a lot of friends and family who come and ask me questions, and it seems like it's the same questions over and over, and maybe the repetition is the key, in that sometimes I tell them what the truth is or what the science shows, and they don't really want to hear it. And so we sort of let it go. And then maybe 2 or 3 days or a week or two later, I get the same question. And my response is very consistent because it's rooted in science. So I just say the same answer over again. And at some point, something, I think the repetition and the consistency touches them, and it helps the message sink in. And then the other thing is, in my experience, meeting people where they are and sort of trying different avenues of convincing people. For example, my cousin was eligible for the booster, and she said she was going to get it, but she wasn't super motivated, and she sort of, I think she was procrastinating. I think she didn't really think it was that big of a deal. And I knew, we had learned about Omicron, and it was becoming a major issue, as it has become a major issue. And so I tried a few different tactics, and at Thanksgiving I said, pretty offhandedly, oh, you know, if you go to this place, they give you a $5 gift card, kind of making a joke. But that was when she said, oh, well, I guess I'll go there then. And she made a plan. And so I really think it's whatever it takes. And you would be surprised that whatever it is that pings in people's brains might not be the thing that you and I might have thought of exactly. So the key, I think, is to keep trying and to be consistent in the message.
I couldn't agree with you more. I think that persistence and that creativity are really key. Dr. Gill, what are your thoughts on this?
Well, from a medical examiner forensic pathology perspective, transparency really is key. And that, for us, is the death certificate. We have to make sure that the death certificate is accurate, transparent, and truthful. I've certified hundreds of deaths due to influenza, to the flu. I've never been called by a family member asking me to remove the word flu from a death certificate. But I have been called by families asking me to remove the word COVID. And so again, we have to resist those pressures and make sure that we are being accurate and truthful in our certifications.
That's amazing, being asked to remove the word COVID from a death certificate. And, you know, pathologists, you know, we are all about the truth, so my goodness. Well, our CAP member laboratories and board-certified pathologists are continuing to lead laboratory testing here in the United States and around the world. However, as we all know, testing is only a part of a comprehensive COVID response. Our message remains the same. We know everyone is tired of this virus, but it's not tired of us, and we will continue to see it circulate, mutate, and infect, especially those people who are not vaccinated. We can't stress this enough, the importance of masking, getting vaccinated and boosted, and continuing to practice physical distancing, especially indoors when you're around big groups. While laboratory testing is important, the real questions we need to answer now are, how transmissible is this virus now? How severe are the new variants in both vaccinated and non-vaccinated people? And are the current COVID treatments still effective when it comes to treating these new variants? Laboratory PCR tests remain the most accurate form of COVID-19 testing. Right now, there are no at-home tests offering PCR-level results. There are at-home rapid antigen tests, but what continues to be confusing to many people is when to use what test and why, as well as the availability and costs of these tests, and more importantly, what tests will be accepted by the U.S. government, our employers, when we're at the airport, when we're traveling, or at our host house for the holidays. Home collection testing involves patients taking a sample and sending it to a laboratory for the results. That will take time you may not have. At-home rapid antigen tests allow you to take your own sample, and the results are available within minutes. Many factors are at play when it comes to the effectiveness of these tests. One of those is following the directions to the letter. I have taken a couple of these tests, and there's a lot to keep in mind. I'd like to ask the group about the importance of testing right, no matter what tests are used, and I'll begin with Dr. Karger.
Yeah, so you're absolutely correct that testing right in all facets of the process is critical to ensure accuracy of your results. And I want to focus specifically on sample collection as an example of how that can really impact your result, because if you don't get a good sample, you could get a false result in the end. And with this pandemic, as you mentioned, we've seen this huge availability, although there hopefully will be more availability, but we've seen testing expand beyond the clinic. Traditionally, lab testing has happened in a clinic or hospital setting, but with the pandemic, we've seen it spread to community testing sites and then this at-home testing that you were mentioning. And so we have a lot of people who aren't necessarily trained in the testing process doing testing right now. And so whenever you have people who aren't experienced with something, there's a greater likelihood for error. And so this is where I'm giving the advice to lay people, to my friends and family who are using at-home tests. It's really important to read those directions very carefully. And I advise people to actually pre-read them. So read them before you start the testing process, and read them multiple times just to make sure you understand each step, that there's no confusion, that you know what's going to come next. The other part of following those collection instructions is that there are going to be certain steps that are timed. The instructions may say to swab your nose for a certain amount of time. And for that, I advise people to use a timer, because as you're going through all these steps, you may lose track of the time. And anytime you deviate from those instructions, again, you run the risk of a false result.
Yeah, absolutely. Great advice. Dr. Cheng, your thoughts?
I think it's wonderful that at-home and rapid antigen testing is going to be more available, and certainly one of the pillars of getting around this pandemic, in addition to vaccines and social distancing and PCR testing. The concern that many laboratorians and many public health officials have is that these test results in the privacy of your home are very rapid, but if there is a positive result, these results don't get recorded in public health data for tracking and contact tracing purposes. So this information is really only as good as much as it's shared. And if it's not shared, then it's really not helping the rest of our communities. One important thing to know about the rapid at-home antigen testing is that it doesn't allow us to sequence or to identify new variants. And as we know, new variants will be coming. And it's really important, especially early on, to be able to detect and track quickly.
Now, those are great points, Dr. Cheng, and I think the point about whether or not that information is used to inform public health, we know that if it's at-home testing, that's not likely to happen. And of course, then there's the decision that patients have to make to isolate if they do have a positive test. Will they do what they're supposed to do with those results? Dr. Gill, what are your thoughts?
Well, as a forensic pathologist, I have a little different perspective in that the deaths, the suspected COVID deaths that we investigate have never been tested. And so we have to do the testing, and that helps us not only determine the cause of death, but it also has important public health information for the family who may be living with the person or the first responders. So again, that's one of the ways that our work actually can help the living. And we've even our investigators have gone to funeral homes to collect swabs samples for testing, and we've diagnosed COVID deaths that way that actually initially weren't reported as a COVID death.
You know, I appreciate you mentioning that. We're going to talk a little bit later in our program today about the important role that forensic pathologists play in the public health infrastructure. You know, back to testing, whether it's negative or positive result, you know, will people report a positive result to their primary care physician as required by the CDC? Will they then isolate for the recommended amount of time? Dr. Chang, why is it important if someone tests positive with an at-home test to immediately contact their doctor? I mean, this may seem obvious, but tell us more about your thoughts here.
There's a few reasons to do it, for both for yourself and for your family and for the community at large. For yourself, certainly, it's to get on the radar of your family doctor. We know that with people who have been vaccinated, their chance of being hospitalized with severe COVID is much lower. Their likelihood is much lower, but it's not zero. And so what you want is to make sure that you set into wheels of motion your own care. And at the same time, your family doctor or the doctors in the health system are mandated to report these as statistics to your local and state public health agencies, which is extremely important because, as you know, the statistics that we see in the newspaper come from public health agencies, and our knowledge of what's happening in our community and nationally and internationally is only as good as each single data point. And finally, because we are now doing more activities, because people are going to events and eating in restaurants, there's a lot more contact happening, which means that contact tracers have to be able to do their job, and they have to know who's tested positive so that they can reach out to those that our patients who test positive have been in contact with to help them as well get testing and see the spread of the spread of COVID within their own local community.
No, that's absolutely right. I mean, when you have information about what's happening in your local community, I think it's a lot more meaningful. We hear a lot about false negative and false positive test results. Getting a false negative result is probably the most concerning of the two. Dr. Karger, can you explain a little bit more about what a false negative result is and what that might mean?
Sure, absolutely. So false negative is when a person who is truly infected with the virus tests negative. And as I mentioned earlier, this could be because they didn't do the collection process correctly, or they're not following the directions of the test. And this is more concerning than a false positive because it may be the case that someone with a negative result feels reassured that they aren't carrying the virus, and they may go out and spread it to others. They may make that visit to their grandparents' house or go to a social event where they're around other people. And so that's why a false negative is more concerning than a false positive, and why it's all the more critical that we test right and follow all the steps of the testing procedure correctly.
If you test negative with an at-home test but have symptoms, I think our viewers should understand that it's always important to follow up with a laboratory PCR test. We at the CAP firmly believe in following the science, and therefore it can't be said enough, getting vaccinated and boosted when appropriate is imperative to halt this virus. Having said that, we also understand the rest of the world needs to be vaccinated to protect us all. I'd like to ask how your laboratories are handling the continued demand for COVID testing, and what concerns, if any, are your labs experiencing, perhaps with intermittent supply or staffing problems? I'll start with Dr. Chang.
Our facility, City of Hope, is primarily a cancer center and research facility. So it means that our patients are immunocompromised and they are one of those high-risk populations. So very early on, I don't think it's an exaggeration to say it was pretty wild. It was a pretty wild time trying to get swabs, trying to get reagents, trying to get machines, and the lab testing industry and the lab testing community has really pulled together to figure things out. There was a lot of problem solving. I'm really proud of the way that we all work together. And now, as we go on into our third year, you can tell that I'm pretty tired. I have a lot of concerns about burnout within my laboratory staff, because we're talking about an area that has been unrelentingly pummeled with new needs and incredible volumes of testing. And at the end of that swab, at the end of that petri dish, is always still a really dedicated laboratory professional. So one issue now that material goods are a little bit better is the people, the manpower that we have. We have a lot of open positions. We have a lot of people taking retirement early. And I have a real concern that this might take a really long time for us to recover from.
Right, right in the middle of all of this, right? We have the great resignation of 2021 to impact our workforce. Dr. Karger, can you share your experience?
Yeah, so absolutely. I would echo what Dr. Chang has said. We are very concerned about our staff. We have about a 12% vacancy rate with our staffing right now, which is 2.5 times our normal vacancy rate for our lab staff throughout our health system. And so it's a huge problem. We just cannot find enough people to fill vacant spots. It's multifactorial, like was mentioned. There's early retirements. There have been people who've been burned out and have moved on to other jobs or careers. And we're also having trouble hiring new graduates who would normally go into clinical lab work. They're seeing that there's a lot of vacancies in a lot of industries where they can get the same pay or higher pay. And so we're having trouble recruiting new people. And the fundamental problem with this is it just puts that much more stress and strain on those staff who've been working relentlessly since March of 2020, handling these huge volumes of COVID testing. And so they really are stretched to the max and continue to be stretched. We're seeing a huge surge in cases here in Minnesota, and our staff are just exhausted by it. I will say the supply chain issues are improved from last year, but we still aren't where we'd like to be. We still have to maintain multiple COVID testing methods. We can't just rely on one because we can't get enough supplies from any individual manufacturer. And so that puts an additional level of stress on those staff because they have to be proficient in multiple COVID testing methods.
Wow. Well, Dr. Gill, from the forensic pathologist perspective, how are supply chain issues and staffing issues impacting your operation?
Well, certainly at the outset of the pandemic, we faced many challenges with getting proper testing equipment. I was even calling up local hospitals asking if, can you give me a dozen swabs? Can you? That part of it has gotten much better, and we certainly don't do as much testing as hospitals and clinics do. But our work, our autopsies are not elective. These are required by statute, and so our staff has had to maintain all of this work during this time, and it's taken a burden on our staff as well. It's been a long couple of years.
Wow. Well, I know I have heard from many of our members that hospital staffing shortages, both inside and outside the laboratory, are leading to bottlenecks in sample collection and turnaround times. I've also heard many laboratories having staffing concerns. In my hospital, we have seen healthcare workers leaving the workforce, as you all have described, after 2 years of pandemic stress. This has included, in our case, medical technologists who work in laboratories with pathologists and phlebotomists. Our phlebotomists are folks who are specially trained people who draw blood for lab tests, and we're having trouble filling those positions. So this impacts all aspects of a patient's hospital stay. Can we discuss any of the other problems this might cause, Dr. Chang, that we haven't mentioned already?
I think as we were all
For instance,
talking about this, and as we're talking about this, and I'm listening to everyone's stories and what it's like in their hospitals, in their communities, I think I'm understanding that there's so many different ways and reasons that it's been difficult, and we've been coping in sort of patchwork, filling our labs and making sure that we can test our communities with safe and reliable tests. I think one of the concerns, or not really dangers, that might be overstating it, but one of my concerns is that because we work so hard and we would never release a testing modality or test results that are not reliable, the idea that it's effortless because it seems possible all the time, I really want to drive home how much problem solving and how much cooperation between laboratories and with physicians such as ourselves back and forth. I smiled a little when Dr. Gill said that he called his local hospital asking for a dozen swabs, because who among us didn't call our colleagues and friends at other hospitals during the early days asking if they just had a box of swabs to spare? But that's all the behind the scenes work. And I really want to reiterate that a lot of this is working on relationships and sort of us working so hard to make sure that the testing and the product and the data are reliable and that you can believe in those. But it's not effortless.
I think that's an excellent point. I mean, I've been impressed with how important these public-private partnerships are as well. I mean, working in a not-for-profit hospital and how closely we're partnering with our public health department here in Floyd County, Indiana. You know, last year, the supply chain left many laboratories scrambling for test tubes, reagents, and other laboratory materials. You know, this last year has been a little better. However, I am still hearing from laboratories that they are reporting intermittent supply issues. Certainly, this is something we are all keeping a close eye on. We will circle back to COVID in a bit, but now I'd like to talk about the importance of addressing racial inequities in healthcare. And that includes changing the way pathologists test for kidney disease. Dr. Karger, can you tell us how we test for kidney disease now?
Absolutely. So there's a couple of ways to test for kidney disease, but the most common way is to measure a compound in the blood called creatinine. This is a compound that's normally filtered by the kidneys into the urine and excreted in the urine. And so if the kidneys aren't working properly, those creatinine levels in the blood are going to go up. It's standard laboratory practice to take that creatinine level and plug it into an equation called an estimated glomerular filtration rate equation. And that equation gives you a result that helps to assess how well the kidney is working or the kidney function.
So that's a mouthful, right? Estimated glomerular filtration rate. We just typically shorten that to EGFR. So can you explain a little bit more about the EGFR equation, and what does this have to do with eliminating racial inequities in healthcare?
Absolutely. So that EGFR equation, or the equations that we use, were developed by researchers as a way to kind of better estimate or assess how well the kidney is doing that job of filtering waste into the urine. And so it basically incorporates the creatinine result that I just talked about, and it also, the equation adds in demographic factors specific to the patient. And those factors include things like age, gender, and then race. And that is why this has to do with inequities. That inclusion of race in the equations has led to inequities in care. It turns out there are two sets of equations that have been historically used. A set of equations for Black patients and a set of equations for non-Black patients. And that has resulted in Black patients receiving different care based on their race. And studies have shown that that means they're less likely to be eligible for things like kidney transplant or therapies for kidney disease because of this correction factor based on their race. taking a step back, this practice of using race to adjust your medical decision making or make changes in the way you treat a patient is called race-based medicine. And this practice of race-based medicine is very entrenched in how we practice medicine. It has come under criticism over the last several years as an example of structural racism, but there really wasn't a big push to eliminate race-based medicine until these tragedies that have gotten a lot of news coverage, starting with the George Floyd murder, Ahmaud Arbery, all these other tragedies that have caused a lot of people to really say, how can we make and enact true change? And the medical field has done that in the last couple of years and said, how can we finally get rid of this practice of race-based medicine? We know that we shouldn't be practicing race-based medicine because race is a social construct or categorization. It's not a biological phenomenon. So we shouldn't be making biological decisions based on race. And so what happened with these equations recently is the nephrology community or kidney disease specialists decided they were going to re-examine the use of race in these equations. And they recently came out with an important statement. They formed a task force and came out with a statement paper that said that we should no longer be using these EGFR equations that incorporate race. Simultaneous to their statement, there was the publication of new equations. So researchers came out with new equations for EGFR that are race neutral. They do not have a race correction factor. And so this nephrology community has said we need to immediately or as quickly as possible change to using these race neutral equations so that we can eliminate inequities in healthcare related to diagnosis of kidney disease.
Yeah, absolutely. I appreciate that background, and I appreciate that the laboratory medicine community partnered with the nephrology community to make these changes happen and to operationalize these changes in laboratories across the country. I appreciate your insights on this, Dr. Karger. If you have any questions about this change, please put them in the chat so we can address those in the question and answer session coming up. Now, while COVID has commandeered the headlines in 2021, there is another public health crisis in full effect: accidental drug overdose deaths. This year, it is not even over, and the death toll just keeps climbing. More than 100,000 Americans have lost their lives this way. That's an almost 30% increase over last year. Along with COVID deaths, this has put a tremendous strain on forensic pathologists and has overwhelmed the death investigation system. Add to that, there's a critical shortage of forensic pathologists. Dr. Gill, can you first speak about the difference between forensic pathologists, medical examiners, and coroners?
Yes, so there are two types of death investigation systems in the country. There are coroner systems and medical examiner systems. And those vary by state and sometimes by county and state. And the main difference is that coroners are typically elected officials, and in many jurisdictions they're not required to even be a physician, yet they're in charge with certifying the death. Now, medical examiners are typically physicians, typically forensic pathologists, and they're appointed by a government body. Both groups are charged by law to investigate sudden, suspicious, or unnatural deaths, so homicides, suicides, accidents. The forensic pathologist is kind of the linchpin of this system because they're the ones that perform the forensic autopsy. And the autopsy is really going to be the one that's going to give you the answer about what happened and why this person died.
Now, what is the forensic pathologist's role when it comes to handling drug overdose deaths?
So by statute, these are required to be reported to the medical examiner or the coroner, and that means that then we're going to have to do a scene investigation, we're going to have to do an autopsy, toxicology testing, and the ultimate goal is to issue a competent death certificate, one that lists the actual drugs that were involved in the death. From a public health point of view, that's important information to share.
Can you share some of the challenges faced by forensic pathologists in their work as medical examiners?
Well, right now, it's really that workforce shortage. There are between 500 to 600 full-time board-certified forensic pathologists practicing in the country. If all the jurisdictions were covered by forensic pathologists, we would need over 1,200. So there's a shortage, and that means more work for the current forensic pathologists, and that can lead to delays in reports, delays in death certificates, and that impacts the family. Families may have their funeral arrangements delayed. They may have a delay in receiving life insurance benefits. So there's some real life effects of this shortage affecting real people.
Wow. I mean, it sounds like we're about 50% down from the number of forensic pathologists we should have in this country. It's incredible. Can you talk a little bit more about how drug intoxication deaths have affected you personally and your work in Connecticut?
Well, you know, Connecticut's not unique. This is happening all across the country. But again, increased deaths mean more investigations, more autopsies, more toxicology testing, more phone calls to families to explain to them why their loved one died. Over the past 6 or 7 years in Connecticut, the number of accidental drug intoxication deaths has literally tripled. And the number of autopsies that we've been performing have doubled. And so again, that just shows the stress that this opioid crisis is putting on offices across the country.
You know, the other thing I'd really like for you to tell us a little bit more about is how the forensic pathologist's investigation of these intoxication deaths actually serve the greater public health and communities, patients, and their families.
You know, one of the big goals of a forensic pathologist is to help the living. And actually, in many medical examiners' offices and autopsy rooms, there's a Latin inscription that translates, "This is the place where death delights to help the living." And that's what we really do think about. You know, if you really want to assess public health, you need to start with the death certificate. Why are people dying? And how can we prevent future people from dying? And so from the opioid crisis, our death certificates can help tell who's dying, where are they dying, what are they dying from. You know, we've seen these 3 phases over time where initially it started with prescription opioids, and then it changed to heroin, and now we're in that fentanyl phase. And so sharing that information with clinicians obviously is very important as well. In Connecticut, we've seen the addition of xylazine, which is a veterinary tranquilizer, added to fentanyl. And so that's important for clinicians to understand that when they have a patient who may not be responding to naloxone, maybe they have to think about other effects. And then obviously ultimately the family as well, that we have a role in their bereavement process and we can try and help answer their questions.
Wow. So, I mean, you know, you all are not just keeping your findings behind the doors of the morgue. You're really out there sharing this information so we can impact the way patients are treated in real time to prevent death. So on top of the drug overdose deaths that you're dealing with, how do COVID deaths affect some of the medical examiners' offices around the country?
Well, you know, COVID deaths, because it's a threat to the public health, those generally are reportable deaths to the medical examiner or the coroner. So we have to do an investigation. Now, some offices will actually issue the death certificate for all of those. Most allow the hospitals to issue those death certificates. But again, it's added work for us during this process. In addition, we have the out-of-hospital COVID deaths that also come to our attention. In some offices, for example, in New York City, they really were able to make a big impact with the unclaimed remains. During the peak of COVID, funeral homes were overwhelmed, hospitals were overwhelmed, families were overwhelmed, and many decedents, the remains, could not be properly, had their proper disposition. And so, for example, New York City was able to step up and really help with that storage problem.
Oh, that's amazing, that important work getting done mostly behind the scenes. Dr. Gill, can you tell us what is happening with the CAP and in the forensic pathology community to address this critical shortage of forensic pathologists?
Well, there are different short-term and long-term effects. I think the main thing we can do is get the word out about forensic pathology and how interesting of a field it is. And the CAP has been very helpful in that. And so people understand what we do. But there are other issues such as helping with maybe visa requirements or visa waivers, making sure that all of the forensic pathology fellowships are not only funded, but they're filled, and maybe we can even increase the number of forensic pathology fellowships, because we need to work on getting people interested in pathology and forensic pathology to kind of meet that need.
No, thank you so much, Dr. Gill. Again, for the audience, please send any questions for Dr. Gill to the chat. At this point, we will turn our attention back to COVID and how the pandemic is responsible in part for creating another possible public health crisis: patients putting off their yearly testings and screenings for cancer. During the height of the pandemic, pathologists around the country began to see a disturbing trend. They were diagnosing more cancer, and those cancers were more advanced. Recently, the CAP produced a video highlighting this subject. We talked with a patient who was diagnosed with colon cancer and treated at the City of Hope in California. Emil August delayed seeing his doctor and getting screened for cultural reasons, but when he physically started to have symptoms, he arranged for a colonoscopy during the pandemic.
I decided to get my colonoscopy during the pandemic because my health and knowing what is going on with my body was more important to me than the fear of not knowing. Not knowing, I think, brings more fear. Do everything that you can to find out what is wrong with you and put the manhood aside.
Yearly laboratory testing and screenings are crucial, pandemic or not. Dr. Chang, what do we know about the importance of early detection?
We know that early detection of cancer saves lives. We know that it improves people's prognoses. It increases the choices that doctors and patients have in terms of cancer care, and it really changes the conversation. This is why it's so important, and this is why we have many decades of research and policy making have gone into making sure that screening tests are understood and an important part of a person's health care.
What are some of the other reasons people are postponing or putting off getting these tests?
I think there's so many reasons, and I've definitely heard from patients and family and loved ones about all the different reasons. And like many things, it came in phases. Early on, it was that no one was leaving their homes, and everything was really scary. We didn't know very much about COVID. We didn't know what was safe and what wasn't safe. And so the prudent advice was to stay home as much as possible. Later, it became getting appointments, because now hospitals and cancer centers and clinics are doing the right thing in decreasing the number of appointments so that there's more space and time in between patient appointments. But that also means that there's fewer slots, maybe. And so it might be a little more challenging to get your doctor's appointment and to get your screening appointments. And I think screening is a lot like a good habit that people have to practice. And if you were always really good about going to get your annual colonoscopy, or every few years your pap smear, and then suddenly we had this internationally involving event that really shook up the way that we conduct our lives, it's easy to fall out of good habits. And that now, I think, is one of the reasons that we are really trying hard to remind people this was a habit that you had, this was a great thing that you used to do, and it's time to come back and continuing doing these things that help with your healthcare.
Yeah, I know as, a busy parent and working full time and doing other volunteer jobs, that getting my yearly screenings is often not at the top of my priority list. So I certainly can empathize with those folks who have put this off. But, what long-range problems does this pose if the pandemic continues at this pace?
We and many published reports have noted that patients who are now getting screened, they're presenting with cancers at a more advanced stage that have perhaps metastasized and have not been detected in the earlier time frame than we would have hoped for, and that perhaps previously we would have gotten. And this has really long-range effects on the patient themselves and their family members, because it means that the tone of the conversation changes. It means that we may have limited options, and there's a lot of heartbreak that comes with something that in many ways was preventable or could have been mitigated with early detection. And one thing I wanted to mention about the screening was that we also realized that it's not the individual person who doesn't want to come in, but with COVID particularly, so many things fell on perhaps female caretakers of the family. They have children, parents, a lot of other pressing responsibilities, children who maybe were staying at home for schooling. And so the idea that they would be able to take time from work, from childcare, to come and get screening testing was just really difficult to navigate. And I'm really sympathetic and empathetic about those situations. And I think it's multifactorial. And so just to say you should come get screening, it might blanket over sort of all the many different reasons that this has been really difficult for so many of our community members.
Absolutely. Dr. Chang, what populations are most affected by not getting yearly tests and screenings?
From an age perspective, we certainly have age-based screening criteria. And the thing that I think, as Dr. Karger had mentioned, as we were looking at all of the different ways that systemic racism affects healthcare and our communities, one thing we know is that COVID and the lack of screening opportunities or access has really disproportionately affected our communities of color and those living near the poverty line. The repercussions of not having access to healthcare, whether it's because of job loss or loss of health insurance, will really be widespread, and the ripple effect can't be underestimated.
So, Dr. Chang, as well as being a physician, you're a patient yourself, and I understand you put off your yearly screenings. Can you tell us a little bit more about that?
So I work at a cancer center, and I came into the hospital every day during the pandemic, and I thought early on, well, I'm not going to go voluntarily on a personal day, go into a different clinic because of risk of COVID. So I was scared, I was concerned, so I delayed. I got my vaccine very early, very thankful to everyone who worked on the vaccine and the massive efforts that it went into making this happen. And I said, okay, well, I'm vaccinated. And then I delayed some more because I wasn't, super comfortable. And also I had fallen out of that habit. And honestly, the reason I finally went was I got an appointment and I just blocked off everything that day and said, this is if you do nothing this day, you will go see your doctor and get your yearly checkup and screening. And that is your one task to do. And I think narrowing it down and making it that one day's focus really helped. And so I think whatever it takes, make a pact with your best friend, tell your sibling, tell your coworker that you guys both take the day, it's conjoining days off so that you can go see your doctor, whatever it takes. But making it a priority and sticking to it was really the thing that helped me sort of get over the bump of my own inertia.
Oh, that's great advice. What is the one important message you would like to leave with the members of the media today about the importance of yearly tests and screenings?
Yearly testing and screening and these accurate results, they save lives. We know this. If I could tell you one thing, it would be to get your vaccine and your booster if you qualify, and then make those appointments and keep those appointments. The thing about cancer is that even though we might be waiting, we might delay, the cancer doesn't wait, and it doesn't care what else is going on. So it's really important to make this part of your routine health care. And the cancer center where I work at City of Hope and at all the hospitals where my colleagues and I have talked about all have procedures in place with physical distancing, mandatory masking, and high vaccination rates. And that is to keep us and to keep you safe so that when you come in, all you have to think about is your task that day and not all these other concerns floating around.
Thank you, Dr. Chang. As you said, cancer doesn't wait, so we can't stress enough the importance of keeping everyone up to date on their health. Now, let's go to some of the reporters' questions. The first question I see is from Cheryl Bird, Core Magazine. Are there any specific age groups that are affected more than others with kidney disease, cancer diagnoses, COVID-19 cases, and the Omicron variant? What are the explanations for age group differences, if any? Dr. Karger, do you have any thoughts on this?
Yeah, so I can speak first to the kidney disease question. So those equations I was talking about earlier that have removed the race parameter, those are used to diagnose chronic kidney disease, which is a disease that tends to happen in older people. So the kidneys tend to people tend to accumulate hits or things with the kidneys over time due to various comorbidities. And so typically that's something that's going to present in older adults. Also to point out, those equations that I spoke about are only applicable to the adult population. In terms of COVID cases, we have seen an evolution in age groups that are making up the majority of cases and being primarily affected by hospitalizations and deaths. Of course, earlier in the pandemic, we saw a lot of elderly patients being affected, but now we have, a lot of elderly patients are vaccinated. They took those steps to make themselves safe. So we are seeing younger people now making up the predominant number of cases for COVID right now.
Oh, thank you for that. We have another question, and I'll direct this first to Dr. Chang. Is the rise in cancer diagnoses attributed to postponed testing for the disease, or is there an increase in the number of cases overall? Dr. Chang.
I think both is the short answer.
Move or change a cause of death from a death certificate. And what is your response to those who request the word COVID to be removed from a death certificate?
Yes, there is a way to amend death certificates. We say that death certificates are written on paper, they're not engraved in stone, and so if we do get additional information that can properly affect our diagnosis, it is correct to amend the death certificate. But when we get families asking us about this, and it's not only with COVID, sometimes it's about a suicide where they don't want suicide on the death certificate. I explain to the family that I have a legal obligation to fill this out properly. I have a public health duty, and this is important for the general public. We need to know how many people are dying from these different diseases, and so that's where I usually fall on it and saying, I'm sorry, I can't accommodate your request, and this is why.
Thank you for that. I have a question from the audience asking how medical students or someone interested in a career in forensic pathology can find out more. Dr. Gill?
Yeah, I would say call your local office, your local medical examiner. I get calls from high school students, college students. I've given talks at high schools. The sooner we get exposure to forensic pathologists, to the field of forensic pathology to folks, the better chance we have of them continuing on. So if you're in medical school, I would say, give your local medical examiner a call and I want to come and see an autopsy. Between my first and second year of medical school, I spent the summer at the Connecticut Medical Examiner's office doing a summer internship, and now I'm the chief there. So eventually, that exposure does help.
Oh, that's wonderful. Great suggestions. Dr. Karger, this next question I'll ask you to answer first. Are we looking down the barrel of another pandemic with Omicron being so transmissible?
Yeah, no, that's a great question. I mean, obviously this is another variant that looks very different than the previous ones, which I think is why there's been such concern. There's a lot of changes in the genetic sequence of this particular variant compared to the ones that preceded it. I don't know that I would call it a different pandemic. I think there's definitely features of this variant that are quite different than the ones we've seen before, and that's something that scientists are rapidly trying to understand. And I think what you said earlier about that COVID pill shows that industry, private companies, as well as academic researchers are very much interested in, does this medication work? How do the vaccines work when it comes to the Omicron? And so I am very heartened to see that this new pill that's just been talked about has been shown to be likely effective against the Omicron variant.
No, great points. Great points. I've got another question, and I think Dr. Chang, this would be a great question. I'd love to know your insights on this. Several school districts over the holidays are providing at-home tests to students. What concerns do you have, if any, with that plan?
I'm heartened by this news that we're trying to make rapid at-home testing more widely available, and certainly with the holidays approaching, that it becomes one of the pillars of, and one of the things that we do before we meet up. My concerns are the reporting and the accurate testing with these tests. As Dr. Karger had mentioned, and as you had mentioned, Dr. Volk, they're cute little kits, and they have a lot of instructions, but if it's your first time ever doing your own nasal swab and developing this test on the little cartridge, it can be pretty foreign, and it's a scientific process, right? Like it's a laboratory test. It happens to be on your kitchen table, but it's a laboratory test, and that means that doing the test correctly and looking at the instructions and following them is really important. And then once you have that result, to not ignore the result if it's positive, or to not ignore it if it's a result your heart didn't want. That's a tough pill to swallow, I think, in terms of now you have a personal responsibility to let your family members know, quarantine if it's positive, and seek confirmatory PCR testing if it is positive. Because as we know, false positives and false negatives do occur. And as we know, these at-home rapid antigen tests are meant to be screening tests. They're not able to tell you which variant or how severe, and also can't do the contact tracing itself. It would be great if it were an automated system where the cartridge changes a color and then immediately notifies those that you've been in contact with. But we're not there yet.
No, we're not there yet, but I think your points are well taken, and to pay attention, and if you're doing an at-home test, follow the instructions, read them before you start, and give it your full attention while you're performing that test. We have another question here. I'll ask Dr. Karger. Is it really important that we know whether someone has the Omicron variant or the Delta variant?
So that's a great question. I think in the US, up to the point before Omicron showed up, we kind of used variant sequencing more from a public health perspective, just to track what was circulating in the communities. But I think with Omicron, a real argument can be made that it's important to know from an individual patient perspective and not just from a general community perspective what the variant is. Because that genetic sequence is so different from Omicron, there is concern that some of the medications that have been developed, like the monoclonal antibody therapies, are not going to be effective. And so that's when it would be important to know what variant is this patient infected with, because maybe certain treatments are going to work better than others. The problem with needing to know the variants is not every state is doing a lot of variant sequencing. It really varies a lot by state. Typically, these variant sequencing efforts are funded by departments of health or by governmental agencies. And so there's a huge variability in what percent of samples are getting sequenced across the U.S.
Oh, those are great points. And those resources are variable for sure. Well, I want to thank our audience for these excellent questions. Our time is just about up. However, before we go, I really would like to thank Drs. Chang, Karger, and Gill for their expertise and insights. I would like to remind the media that pathologists are physicians and clinicians that touch all aspects of medicine. Following the science is key to curtailing this virus. We also should never underestimate the importance of accurate and reliable testing. Using at-home and rapid tests if a laboratory test isn't available is important, especially if people aren't feeling well. And we can't say this enough. Please urge your readers, listeners, and viewers to continue to mask and practice physical distancing, especially if people are indoors in a closed area and in a large group. Please do visit our multimedia newsroom to view this briefing again and for other information about the clinical practice of pathology and pathologists. As you write and report your stories moving forward, please make sure to reach out to the CAP for expert information on laboratory testing and diagnostic medicine. Have a safe holiday, and thank you for joining us today.